Hello everybody. Today we'll be reading about hepatorenal syndrome. So many times when people see any patient with CLD and they see that the patient has any kind of renal dysfunction or even a raised serum creatinine levels, they are very quick to jump and diagnose it as HRS or hepatorenal syndrome. But however, as we'll be finding out during this video, that HRS is not that easy to diagnose, and it is in fact a diagnosis of exclusion, and has also been new terminology regarding the classification of HRS. So let's learn about HRS today. So as I already told you, it is a diagnosis of exclusion. So what exactly is the criteria for diagnosing HRS? So the patient must have cirrhosis with portal hypertension with ascites, and the patient must have AKI according to the ICA criteria. So what exactly is the ICA criteria? They should be increased in serum creatinine levels by more than equal to 0.3 mg per deciliter in less than 48 hours, or the serum creatinine should increase by more than 50% in less than 7 days from the baseline, and the patient should have no history of nephrotoxic drug use like NSAIDs, aminoglycosides, etc., and the patient should not be in shock, and also there should be no improvement in the renal function and the serum creatinine levels with albumin given at 1 mg per kg per day for 48 hours or withdrawing diuretics for 48 hours. Many a times we see that CLD patients for ascites are prescribed diuretics like furosemide, and they are in fact the ones that are causing the renal dysfunction and the increase in serum creatinine levels, and it is not actually HRS, and the patient actually improves when we give him volume expansion with albumin and withdraw the diuretic. And the patient must also have structurally normal kidneys. So what exactly does this mean? The patient should have normal kidneys on USG, meaning the patient should have normal kidneys on USG, like the CMD should be maintained, the kidney size should be normal, the patient should not have small kidneys. Also, we must do urine analysis of all patients. Why? Because many a times we see that CLD patients develop secondary IgA nephropathy, and to rule this out we need to do assess the patient for proteinuria, and the proteinuria should be less than 500 mg per deciliter, and hematuria, which should be less than 50 RBC per high powered cells. So what exactly is the new classification for HRS? Earlier HRS used to be classified as HRS type 1 and type 2. However, this classification is no longer in use, and now we use HRS AKI and HRS NAKI, or HRS not associated with AKI. So HRS AKI is pretty much diagnosed and with the criteria that I told you above, and it is a very life-threatening condition with the median survival without treatment being 2 to 4 weeks, and it is mostly precipitated by SBP, which is spontaneous bacterial peritonitis. However, HRS-NAKI is HRS not associated with AKI. It is further divided into two types, HRS-AKD and HRS-CKD. So what exactly is HRS-AKD? HRS-AKD is that means that the increase in serum creatinine is less than 50% from the baseline, the duration is less than 3 months, and the eGFR is less than 60. And HRS-CKD, the increase in serum creatinine is less than 50% from the baseline, the duration is more than 3 months, and the eGFR is less than 60. HRS-CKD as well as HRS-AKD are mostly seen with refractory ascites, and the median survival, though slightly better than HRS-AKI, is not that much. The median survival is only 4 to 6 months without treatment. So I hope you like this video, and we'll be soon signing in with another video in which we'll be learning another complicated topic.